Okay, good morning, everyone. This is Phil Pugh, Director of Emergency Management here and Regional Healthcare Coalition Chair for the Hope Coalition. We're going to get started here momentarily. As just a administrative reminder, this meeting is being recorded. So if you do not want to be recorded, but want to participate, you can stay. But if you don't want to be recorded, don't want to participate, please log off now. This will be uploaded to our YouTube page at a later date and time, hopefully by early next week after we do a few edits. Also, if you are calling in on a phone, please remember not to press the hold button. as we'll get probably some hold music that we don't want to hear, and folks won't be able to communicate effectively. So please use your mute button effectively so people can talk. Um, just to get a quick, um, mic check. Can someone give me a thumbs up either in the chat or come on and tell me if they can hear me clearly? Also, if you can see the slides. The slides have been uploaded. I know I just got a question from Lee. He's over at Shiloh. I see a thumbs up. Was that for vocals or was that for both? You could throw that in the chat or unmute yourself and feel free to talk.
Got both.
Phil, this is Tina at Fayette County Hospital. So I'm on the phone currently, but I'm trying
So to my
get our
folks
laptop
over
so I can talk.
in Shiloh, are you able to see the screen and everything? Okay, I see unknown user says they can see both. Okay, good. Can someone talk to me so I can make sure I'm getting audio from you guys? So we're gonna have to talk during this during this excursion today. So
Phil, this is Tina at Fayette County Hospital. Can you hear me?
I'm hearing nothing. Give me one sec. All right, just change my audio configuration here. Tina, I see you out there in Fayette. Can you give me a mic check?
Hi, Phil, it's Tina, and I'm on the phone. We're trying to get our the laptop up so we can project it on the screen.
Okay, can you say that last part one more time?
We're just trying to get our laptop up so we can project it on our screen in the room.
Okay, gotcha. And Nancy, I think I did hear you as well. Thank you very much. Okay, well, we'll get started here slowly and begin to move through. Oh, we're getting, I think, the folks over at Shiloh's giving a call. Stand by one sec.
Bill, do you need us to check in? This is Gateway Regional.
All right, we'll be back here.
Not yet, Danielle. We'll,
Okay.
We're going to do a roll call here in 1 second, just trying to make sure we got all audio and video at all the locations. How are you guys with audio and video?
We're still working on it.
Okay.
Thank
No worries.
you.
We'll give folks just another minute or so to get situated, and then we'll slowly roll this out so folks can catch up. So no sweat. I'll let you guys all know, a secret. I'm hopped up on Diet Coke, a caramel frappuccino, and Cheetos hot fries. So we're gonna have a good time today, hopefully. All right, we'll go ahead and slowly get started as audio and video begins to pick up. We won't go too far until everybody's there, but we will go ahead and get some of the general items out of the way. going forward. Again, as a reminder, please make sure that you are muted if you're not talking. If you do have a question, please raise your hand. Use the raise your hand button function so I can double check where you're at. So we'll go around. Welcome to this year's medical response surge exercise. This has taken place of the coalition surge test. So for those of you who participated in 2018, 19, and 20 with the coalition surge tests, ASPR changed their take on what that was. In the original coalition surge test, it was more of an evacuation drill. So the placement of patients from hospitals within the coalition to other hospitals within the coalition. And Lee, you just shared that on your screen. So I'm going to take back over and share the slides again, share my slides again. All right, give me one sec.
Phil, you should be able to share now.
Yeah, okay, I'll try again. Yeah, because I see you guys. So stand by one sec. It should be coming back up on your screens again. Perfect, awesome. All right. So as we were saying, this takes place, the coalition surge test, which was more of an evacuation and absorption of patients from one hospital or multiple hospitals in a region within that region to other hospitals within that region. This exercise is more focused on an actual incident or an event, something that's realistic and plausible, that generates lots of patients to where you would do a traditional surge. So we'll talk about that a little bit here in a moment. So here's our agenda for today. We'll go through our introductions and just general overviews. We'll do a review of the scenario here, and we'll go through 4 independent modules, and then we'll conduct a hot wash and then conclude. I think we had this scheduled for 4 hours. That's the targeted time according to the ASPR documentation. I will say this, that we've never done a CST that lasted an entire 4 hours, and I don't anticipate today going a complete 4 hours either. And to Tina, no, we did not send out the slides because some of the answers are on there, but I can forward you a copy if you would like in maybe a PDF format if you would like, because it's kind of a large document. The slides are pretty heavy. So let me know if you need a copy of the PDF version and I'll get one to you during it. Are you guys still having difficulty with projecting up on a screen?
Yes, we're having trouble, but because they remoted into my office one, we cannot get, we see everything.
Okay.
Let me just like that, Bill, and I can hear you.
Okay, not a problem. So I will get you a copy though. Okay. So all the introductions, I've introduced myself. I know across the region, not everyone from the region is participating. I know we have this, but we will have hospitals, health departments, and I believe we do have a few EMS personnel online. So we'll get a good perspective from a good swath of folks here in the healthcare space. So we'll talk about those spots here in a minute. But again, the 2023 medical response surge exercise is basically a plenary moderated breakout group format, and it is designed to have you take a look at your policies, your plans, and evaluate how you would respond to a given scenario. Okay, out of the bonus of this is that during this MRSE or the response surge exercise, you will be able to get credit once we put out the AAR for some of your CMS requirements. We're going to also be validating key components of our regional chemical response annex, and we will be conducting a redundant communications drill today as well. So killing a lot of birds with one stone. These are the participants who signed up. So Gateway Regional, folks out at Boyd, a few of our HSHS partners here, St. Elizabeth's, St. Joseph's Highland, both Memorial Hospital Belleville and Shiloh are participating. Good folks out at Fayette, down at Sparta, and several health departments. So what we'll do here is we'll just go right down the line for those to make sure that we're on. We'll start with Gateway. If you could just jump on, do a quick introduction and a look at the type of folks that you guys have in your, I won't call it your command center, but who are participating today. And we'll just go right through the list. So we'll start with Gateway.
Hi, this is Rick Wolf at Gateway Regional Medical Center. We've got infection control in here with Brittany and Dawn.
I've got my microphone.
Hello. We've got Kenny James in here. We've got Scott Klosterman. We've got Danielle Rahman representing pharmacy, ER with Kenny James, as well as Ashley Klein. Case management with Ashley Marshall, and security with Dina Yancey.
Awesome. Thank you, Rick, and welcome to everybody there. We'll go up to Boyd. Nancy? Nancy, if you guys are speaking, you're muted. Still not hearing you, Nancy. We're gonna go down to our HSHS folks at St. Elizabeth's.
Good morning, Phil, again.
Good morning, Brad. Just so everyone knows, Brad and I had a good conversation around 2:30 this morning with the incident out in Highland. So this is very apropos. So go ahead, Brad.
Yeah, it's perfect timing. So St. Elizabeth's and St. Joe's Highland, we're kind of combining together and working with this. So Patrick may be in transit right now. I'm not totally sure, but we've got emergency management at St. Elizabeth's. We've got Dawn with EMS, our EMS coordinator. Our emergency department's represented. Erica Chamness is involved. And that's it so far.
Great. Thank you, Brad. Hopefully folks are getting some rest after last night, but hopefully those that are here today will be able, they're caffeined up and they'll be able to move through without issue. All right. So we'll go over to Memorial Hospital here in Belleville and Shiloh. It sounds like someone is unmuted that maybe in the back. I'm trying to spot them. See if I can mute them so it's a little clearer, but go ahead, Memorial.
Yeah, so this is Jeff. We've got several folks in the room. We've got our emergency management folks. We've got nursing. We've got emergency department. We also have some members of the leadership team.
Thanks, Jeff. And now Tina out at Fayette.
Hi, well, I have a couple of folks here, Phil, and one of them is the director of our inpatient services, and the other one's the director of our plant operations. And
You cut out right after plant ops. Can you say again, Tina?
and me.
Okay, and you. Okay, very well. Thank you, Tina. Now Dan in Sparta.
Yes, Bill, Dan's here. We got some feedback.
I am hearing that. Yep.
Yeah, Phil, Dan's here. I also have Dale Worthington, who's going to serve as our incident commander. We have our quality folks in the room, Joanne, our CEO's in the room, and we'll have participation from Paula, our nurse manager.
Awesome. Thank you very much. And we'll double back to Boyd. Nancy. I see that you're unmuted, Nancy, but we're not hearing anything. You can, if you would like, you feel free to type it in the chat. Yeah, well, as we do that, we'll go over to some of our local health departments. I see a good list of health department folks, and I don't know if I can do it alphabetically through here, but so if you're from a health department, please sound off. Just take your time and we'll make sure you're captured here. What health departments do we have on?
Hey, Phil, this is Wendy at Bond County.
Thank you, Wendy.
Vicky with Monroe.
Gotcha, Vicky. Thank you.
This is Deborah Grapperhouse with Ramsey.
Gotcha, Deborah. Any other health departments on? Once, twice, thrice. Okay. And take another look just down the, just to make sure I'm not missing anyone. Anyone from our EMS agencies? I did see Jeremy on earlier. And any other external agencies? Once, twice, thrice. We do have a few other folks that are from Memorial represented that I do see. I know Dennis from our ED here at Belleville, Ryan Massey from pharmacy is on as well. So we'll go ahead and move forward. Again, the overview, these are kind of the themes for each one of the modules: communicate, coordinate, respond, and treat. And we'll have a great discussion throughout each. I don't want to belabor that point. These are what you should have access to as being a part of the region, and will assist you today with the exercise. So D4H, which is our common operating picture that we share across the region. EM Resource, which is the state's bed accountability board and tracking. It is a common operating picture within that regard in and of itself. And Starcom 21 radios, we'll be using that today. We try to be a little paper friendly to reduce on printouts and sending everything there. So if you can see that QR code on the screen or that link, you should be able to access both. So if you want to use your phone or whatever mobile device that you have, you can scan that and it will take you to a section that covers what we're currently talking about. So when we get to an area where there's questions and we take a time out to discuss those questions, and maybe it's not on the screen. Oh, just had a why'd that go out now? That's it's 10:20. It just went out. So some of you may have received the EM resource notification. We're going to talk about that here in a second, but we'll allow that to play out. But you can scan those QR codes, and it will allow you to view whatever that documentation is or those questions on your own, should you need to. So the objective of today's exercise primarily is to demonstrate the ability to surge 20% of the region's licensed bed capacity, which is right around 400 beds within 1 hour to a mass casualty incident, basically to test our coordination capabilities, evaluate the effectiveness of communication, and assess our ability to rapidly triage and provide appropriate medical care to a large number of casualties of varying degrees. And we'll get an opportunity to review and evaluate our decon procedures for both effective individuals and response personnel. The part where we talk about assess the ability to rapidly triage, many of you will receive, or like when Scott is over at Shiloh, over at Gateway, and Sean is over at Shiloh today, there's an offline portion of the exercise that we will liaise with your, or rendezvous with some of your ED counterparts. So it's basically kind of a test that we'll be going through today. Very low threat, but should be very informative for us. And we'll take that information back and compile it with other information that we've collected. So in module 1, we'll talk about it. This is the scenario. We're starting off, basically, think about this as Wednesday today, our weather conditions. I made these weather conditions up several days ago, so it kind of mirrors what we're going through today, but it's hot. It's hot and humid, and the forecast for this weekend, for Saturday, is getting up to 103. and with thunderstorm warnings, with a lot of winds coming out of the southwest over the next several days, fairly steady winds. We have some current events, mass gatherings on Saturday. We have an NHRA drag race out there at the I always the I can't remember the name. Leo have to help me with the name. I always
Worldwide
forget.
Technology Raceway.
Exactly. There you go. The WWRT or whatever. There we go. That's a we've done several events out there, and it's been quite the show from NASCAR, and now we'll just say some drag racing. Got a cards doubleheader with the Cubs on Saturday. Art in the City, expecting around 25K, and City soccer game 18 to 20. So with all the anticipated folks coming in, we're looking to balloon up in the St. Louis Metro East area around 100,000 folks. Cooling centers, with the reduction of COVID protocols, cooling centers are beginning to see more displaced and unhoused citizens try to seek shelter to get out of the heat. So if you want to scan those, you can see that information on the regular there. So that's where we're at. So we're going to kind of fast forward a little bit in the scenario. But before we get to that portion, when your organization receives this level of information, okay, um, what methods does your organization use to receive notifications on mass gatherings, severe weather, and security related information? How does your organization communicate these type of community events across the region, internally to your staff, employees, and potentially visitors? Does your facility participate in event planning efforts? If so, how and what are they? Again, you can scan that QR code and sit there, but we're going to pause just for 5 minutes and allow you guys to discuss within that. We'll come back and then we'll kind of do a quick round robin with some of the hospitals to see how this information is presented. So we're going to go ahead and move on here, and we'll see you in about 5 minutes. If you have questions, please throw them up in the chat, and I'll try to answer them there. Okay, just a quick 5 minutes. So we'll kind of go around the room. Well, I'll say around the rooms, and we're gonna start with. I'm doing eeny, meeny, miny, more in my head. We're gonna start with Tina and the good folks at Fayette. Um, Tina, what methods does your organization receive notifications on mass gatherings, severe weather, and security related information? Tina, if you are speaking, you are muted. Once, twice. Oh, go ahead, Tina. Okay. We'll move over to uh, the good folks at Gateway. Gateway. If you're speaking, Rick, or the team at Gateway, we cannot hear you. And Nancy, it seems like your audio is what's causing part of the feedback here. So I'm trying to keep you muted.
Hey, Phil,
Yep,
can you hear us okay? Danielle, you,
we
go ahead,
got
say-
you.
Okay, we were answering the
Sorry.
questions and you couldn't hear us, I'm sorry.
I figured as much. It's okay. Go ahead.
So our first answer would be, a mass text notification system, but we also, if people are on site, we would, act accordingly to our plan, either call a code or, discuss at safety huddles, whatever the case may be. And the second question is also discussing at safety huddles, and we just did that with the race that was recent. We were prepared for increase in trauma or hydration issues, to our ER. And then for regional planning events and efforts, we are part of the EM resource notification system and the Hope region. And then I guess we haven't really been like involved in planning, but we have been participating. We were part of the hospital tent at that race. Is that kind of what you're looking for?
hosting events.
Yes. So as far as the first question, it's more looking at what external mechanisms provide you the information so you can internally relay that. So do you have any external subscriptions or state level systems that provide you information on these type of events?
I mean, nothing on a rapid basis. I mean, we get emails from IHA, we get emails from IEMA. Nothing that would come through on a daily, regular basis. But, EM resource, we get that as frequently as it pops up.
Weather alerts, so we.
Weather alerts, right?
Yep. Okay. Okay. Great.
Amber alerts, stuff like that.
Understood. Not a problem. Okay. Perfect. We'll go over to the good folks at HSHS. Brad.
All right, hello.
Yep, got you loud and clear.
So initial communication typically is done a couple of ways. We'll get outbound, us being a resource hospital. We tend to get outbound information for any kind of activity that is got any kind of mass casualty implications to it. Our services are really good at outbounds. Whether they give us an outbound when they arrive on scene, they'll typically give us a call. So our initial notifications locally would be that way. With us being part of a larger system, To give you an example, the exact way St. Elizabeth knew about what happened at 2:30 is our house supervisor networking. So the St. Joseph's Highland, give you an example, heard about a situation, they notify all the house supervisors at all of our facilities. For monitoring things a little bit more proactive instead of reactive, we are very vigilant with our EM resource product. It is monitored by several people continuously in our facility. We use one product called Storm Geo. That is our weather related. That is a targeted notification, not a regional. So where your weather networks and so forth, they'll give you updates that have to do with an encompassed or circled area. This particular product we use and pay for is actually targeted to the address of our facilities. Notification local through each one of our ministries. We use a product called Doc Halo. We have gotten quite aggressive with our Doc Halo projects on notifications of key personnel or certain levels of personnel within our facility itself. And then system-wide notification, we have the product. It was SendWord now. We're updating that to the complete unsolved product, and that will thus set up tiered levels of notifications for response that is system-wide. We do have an active emergency management department. That's all I've got right now.
Got it. And obviously, you guys are always on the coalition calls. I'm not sure how much you guys participate with the local LEPC here with Sam and the good folks down here in Belleville, but all other great places to get some of that information. Okay. We'll pause there. Did anyone outside of what we've heard, did anyone have any additional items that they thought would be relevant or prevalent that they would like to share that their organization uses?
Phil,
and how
this
they
is Tina.
communicate? Go ahead, Tina.
Yes, we also monitor our city and our county frequencies continuously. That helps us along with the NOAA radio. And we also have, the massive alerts that do go out also. So I think that's the only addition we have.
Thank you, Tina. Anyone else? Once? Twice? Okay, thank you, Nancy. I see she put in there, they use, obviously they use Siren, and everyone, all of our hospitals should definitely receive notifications from IDPH's Siren, and call multiplier.com for internal notifications. Okay, and that's how they get their information out. Siren's good place. If you're not also receiving anything, if you do not have a ton of information either from the STIC, the Fusion Center here in St. Louis, or the good folks out of Region 5, if you're not getting a lot of stuff from Kelly Hun, H-U-N, in your inbox, from IDPH or the State Terrorism Office, sometimes you may be missing out on some of those. So we're probably gonna collect a lot of that information and republish that out. We try to send those out as we review them. Lee and I try to send them out for anything that may be relevant to, again, mass gatherings or things of this nature. And obviously we share all of the NWS weather reports that we do get and attend all those calls across here. So, okay, that's the basics. One other question that I would like to ask that we can kind of freeform here is that are any of the hospitals, when we see major gatherings like this, changing their staffing model during that time frame? Does that occur? And feel free, anyone can answer that. Yes, no right or wrong answer.
Can you
Go ahead,
repeat
Brad.
the question one more time, please? I was chatting with our group here.
No problem. Given the information, let's say, you're on a coalition call and it's the you're going to have 125,000 folks at the Scott Air Force Base Air Show on date 1 and 2. Do you guys adjust your staffing model at all to prepare for items like that, or put any additional folks on call during those time frames? I see Jeff says no. So for Memorial, I knew that answer. I'm cheating on the test apparently. My folks down in Sparta, Dan, how about you guys? Like for, I guess next in about 9 months or 9 months or so, 10 months, we'll have the um, eclipse again. Did you guys staff up for that major event down there?
Actually, this is Dale.
Oh, Dale,
Phil.
sorry, go ahead,
Yeah,
Dale.
it's okay. We did not staff up, but what we're going to do is we're going to flex our staff depending on the need, which I would assume everybody is going to do. If it turns out that we're going to have that some type of event happens out of this, then of course we're going to bring people in as we need. But we did not increase staffing for the last uh, eclipse. Now, one thing that we do have down here every year is the the Amateur Trap Shooting Association's annual grand, and that's getting ready to take off here at the end of July. And in the first year that we participated in that, we did increase staffing, but it turned out that it really wasn't necessary. So again, what we do is we just look at what the possibilities are, and then we flex our staff as needed.
Got it. Okay.
And actually, we attended a meeting today in preparation for the grand with people out at the grand.
Perfect. I know that's the next big thing going on down there. So thank you, Dale. Okay. We'll go ahead and move on from that one over into module 2. So scenario update. So I know we're ahead of this time frame, but at a little after 10 this morning, an East St. Louis-based MedStar ambulance crew contacted Memorial Hospital Belleville to inform the RHCC of a train derailment. An extremely loud explosion was heard throughout the Metro East. It appears that a northbound train has derailed at the rail switching station off Collinsville Road in East St. Louis. Illinois. A total of 11 cars have derailed, resulting in 7 pressure tank cars being damaged, releasing their contents into the atmosphere. Reports from the scene indicate there several pressure tank cars are marked with the UNNA numbers of 1017 and 1052. A visible cloud can be seen in the wind uh, carrying from the scene. All traffic on I-55, 64, and 70 has been diverted due to the release and direction of the wind. Ambulances are being diverted to local Illinois hospitals due to traffic backups across bridges that are seemingly backed up going into Missouri, into the St. Louis area. Okay. Again, if you want to scan that code, you can, or click on the link there. I'll move over here to this is the location, the general location of that incident, which you are seeing is one of the street view maps in D4H in our common operating picture, which is there. Inside there, if you guys are, you'll probably see that I just put a notification within within D4H. So that's the general notification. And there's probably a few things that you can notice about that general location. It has made the news very rapidly, and it seems as though more information is to come. Skycam reports out there are showing a blazing fire and derailed cars at that switching station. So this is what you would be seeing live right now. Should you have received the notification earlier through EM Resource that stated that there was an incident, a train derailment, and this is what you're witnessing at this point in time. More initial scenes or footage from the scenes. So, all right, this will be our discussion portion here. So these are the questions. So you'll know who these are going to in some instances. Starting with the first one, what should the charge nurse at the RHCC do with the information received? What are the corresponding chemical names for both UNNA 1017 and 1052? At your specific facility, who can identify these chemicals? And that means, let's identify, look up, provide information on. Um, what's the RHCC's role and what should be done with this information? What is the role of the local health departments in the districts, both inside and outside of St. Clair County and Madison County? What regional EOP response level would you recommend? What personal protective equipment do you have on hand to protect staff? And what type of patient support supplies can your hospital provide to EMS and fire personnel to augment the supplies on the ambulances and everything that's heading to that scene? So I'll ask that you guys, I'll give you a moment to either capture that QR code or click on that link. I will also put that link in the chat box so you guys can access the questions at your leisure. And then we will pause for 10 minutes so you guys can discuss. And then we will come back. You discuss amongst yourselves and we will come back and review that discussion. So any questions before we go on to our 10-minute discussion break? Hearing none, we'll go ahead and pause for 10 minutes. All right. Okay. That was a quick 10 minutes. So we're going to jump right into it. So we'll start with this is going to be targeted right for our memorial team here. So I don't know if Dennis or the folks in the boardroom would like to answer this, but what should the charge nurse at the RHCC Memorial Hospital Belleville do with the information received from MedStar Ambulance?
This is Dennis. So the charge nurse receives the information. They do have the chemical book there at the desk. It is chlorine gas and anhydrous ammonia would be what the placards are standing for. Once they receive the information with the level of potential victims, they'd call with as much information as they can. They'd call the house supervisor, and that would be relayed to the AOC on call.
Okay. Now I'm going to jump to one of the AOCs on call, given that information. So AOC on call, Jeff Dossett calling you. What are you doing when you hear when you get that call from whether it's the house supervisor or the ED directly?
Well, I mean, typically we go through a conversation and triage process around, what resources do you need? What do you, who do we need to potentially notify or call in? If we think that we're going to have a lot of folks who we need to respond to, we will make sure that there's a notification that goes out. So a lot of times that means we call Phil or somebody on Phil's team, but if unavailable, right, we would send out an Everbridge to at least managers and above to let them know what's going on and what our level of response could need to be.
Very well. Thanks, Jeff. So yeah, it's call Phil or Lee. And that seems like the next step, right? Okay. Hey, what are you doing? So yeah, and at that point, I can answer myself, but I'm gonna go over to Lee and ask, what's the RHCC's role at this point, and what are we doing with that information?
So our primary goal is going to be to distribute information in a timely fashion to those that need it, and help to establish and collaborate with our other partners out there, whether it's EMS, EMA, fire, whoever can help provide some ground truth and allow us to be prepared for what's coming in.
And what
This is Cindy Bray. This is Cindy Bray from Alton Memorial. I'm sorry to interject, but we have hydrogen fluoride for 1052, not anhydrous ammonia.
Yeah, it should be anhydrous. It's anhydrous hydrogen fluoride. So yeah, we're gonna get to that part. But thank you very much. Very astute observation. So great. Perfect.
Thank you.
No problem. No, perfect.
Yeah, so just so you know, the chemical you picked there is a non-transportable by rail form, just so you know.
Yep. Could be it could be also a tanker that is that looks like a rail car that may be in that accident, right? Maybe. I don't know. So okay, so in that, so Lee, I'll go back to you. What are we doing with that? What will we do with the information? What method are we sending that information out?
So we're going to distribute information utilizing EM Resource, the EMSR4 talk group on the Starcom radio. We'll also, as necessary, send email, phone, text messaging via our D4H interface, whatever, and any and all means of communication possible at this point. At the same time, we will ask, more than likely set up either a Teams room or some kind of a call bridge and ask to have representatives from the affected facilities dial in and, again, keep that open line of communication. We will also have our D4H channel open to be able to do, updates and resource requests if there's resources that need to be pushed out, whether it's decon equipment, trailers, things of that nature.
Indeed. Thank you. Thank you for all that. And as we were doing that, so I'm acting in real time as best I can with giving that information. That's exactly what we would do. Just like we did last night with Brad and team, we sent out the MCI alert. And now you folks, a lot of you folks have probably already received that MCI alert, and that's for the entire region. So we would need to begin filling that out. So for as we are working through the scenario, that should be something that should be updated. Inside the message, it went out at 11. It said it needs to be updated within the next 15 minutes. And I will ask John, since John is on from MedStar Ambulance, why is it important that we get that information updated in a timely manner
Oh, it's
inside of EM resource?
again, that's something that a lot of folks should live on. It gives you knowledge of what our capabilities are of these facilities. It's going to be our closest facility. And again, when, major interstates being shut down, just like our STAR over the 4th of July, there were agencies that were caught on 64 because of 64 being shut down. But again, just the awareness of what is going on is highly important.
You're breaking up just a little, John. You're breaking up just a little bit. Try again.
Again, the bottom line is just that situational awareness of what is going on is vital to not just your EMS, to everybody that's involved in this region that provides healthcare. Again, just your first MCI alert for today's drill, just being able to see which hospitals were paying attention. Of course, now that screen view has changed, since now you're asking for a bed query or an actual, triage category. But just seeing which hospitals acknowledge that there's something going on. Again, that situational awareness, especially, again, I know I'm somebody that lives on EM resource track, but it lets me start pushing out information to my crews on what we need to do or what we need to get ready for.
Thank you. And as like the triage officer who's on scene, they are in part using that information to help initially direct where they want to send folks. And I've just put in the chat for those of you who may not be in EM resource directly, you can kind of see what that starts to look like. That's live information right now. So hopefully we will have at this point we've got what 1, 2, 3, 4, 5, 6 out of 19 who's updated. So, and again, so if you're on this call and it's not being updated, contact whoever your liaison at your organization to get with the ED and get a sober assessment of exactly how many folks your facility can accept. That is part and parcel to this exercise. So we'll do that there. So inside that message as well, I will relay that it does talk about how many red, yellows, and green in the triage sense your ED can accept, but it also requests for a bed update. Okay, so we do our bed availability updates every day across the region between the hours of 0600 and 0800. That's been our agreed upon time from the region. So it gives us a good starting point for everyone. That's right around everyone's shift change across the region. But that information changes. So that's not all day. And, we want to know what staff beds you can kind of surge to. And this would be one of those instances where we want to make sure that we are providing a realistic expectation of what that looks like. So, and we'll talk about that here in a bit.
Hey, Bill,
So,
just
yes,
I'm
go ahead.
sorry.
Go ahead, John.
Yeah, I don't know, I might have been cutting out before I said that. But again, that initial response, getting that alert put out is going to be vital for us as EMS to do that load balancing so we can get the RHC on board with us and fill them in. So it's going to be the field personnel making those decisions where patients go. until we can get that help or that extra support. So it's vital that that information gets put out as soon as that alert goes out. Sorry, I hope that.
No, I appreciate it, John. We need that perspective here. Okay. So in that, we'll shift down just slightly. At this point, we'll move over to some of our local health departments. Maybe I'll start with Vicky. What's the local health department's role in a situation like this? What are you guys doing once you've been notified and things start kind of rolling? Vicky, if you are talking, you are muted. Okay. We'll move over to maybe Wendy. Wendy, local health department's perspective for an incident like this.
So an incident like this, we've thrown around different things. We did do a train derailment exercise last year. One of the things the local health department may be asked to do is get word out to vulnerable populations how to shelter in place if necessary, or find a way to coordinate reception centers for people wanting to ask questions so that people don't go to the site of the emergency, but that they can ask questions about people taken to the hospitals for the surge, that they can provide an information kind of function and keep people away from the hospitals and the accident area.
Thank you very much, very much. Okay. So I'll look to some, maybe this will be a pop quiz for those of you who remember exactly the 5 response levels in our EOP. What response level would you recommend for this one? And I'm going to pick on Brad. Brad, we're going to pick back on the good folks at St. Elizabeth's. And I will say this, if you don't recall it right off the top of your head, if you don't have the plan available to you, it does follow the FEMA typing for incident scope and scale. So listed as 1 through 5. So what level would this one be? Brad, if you guys are talking, you are muted.
I am not talking. I am trying to research an answer for your question. So I cannot answer that right now. I am trying to look it up in our plan.
Okay. Well, I'll let you
Dawn
continue to
says
look.
3 or 4. So if she is correct, then it's all Dawn.
Okay, so here,
disaster 3 is situation involving hazardous materials beyond the capability of a single response team. So I could say that.
So if you look at
So we're going to go with 3.
Okay, you go with 3. Okay. At a minimum, it would be a 3, and that's where we started at. If you were to look at D4H, that's how we categorize it. At the minimum, we categorize it as a 3. As soon as we started, the first one, the first level, 5 being the least of all, 1 being something of national significance. So 3, multiple agencies coordinated. So definitely a 3. So we started with the alert at a 5. Moved immediately to a 3 upon hearing that there was a crash and multiple response agencies were there, and it crossing both sides of St. Clair County, Madison County. And then if you guys are familiar with the latest Palestine incident, you guys, the train derailment there, that was one of national significance, which would have been typed at a FEMA typing of a 1, maybe a 2. So in this instance, what Phil would do is once this would, for us as a region, this would probably be a 1. This probably be one of the biggest things that we'd probably have to handle, in my estimation, at least right now, given the certain circumstances. So that's what I would recommend. We'll go up to the good folks at Gateway. What PPE on hand do you have to protect staff? And what type of patient support supplies can your hospital provide to EMS and fire personnel to augment their supplies on the ambulances and their rigs out there? Rick and or Danielle, if you are talking, you're muted.
Can you hear us?
Gotcha. Lima chart, loud and clear. Yep.
Okay. Could you ask the question again, please? Somebody was talking to
Nope.
me.
No problem. Yeah. What PPE, what personal protective equipment do you have or your organization have on hand to protect staff that may be dealing with some of these chemicals potentially? And what type of patient support supplies can your hospital provide to EMS and or fire personnel to augment their supplies that they have out there in the field right now, patient care wise?
We've got, chem suits, we've got PAPRs, we've got, other types I can't off the top of my head think of, breathing apparatus, that they used during COVID. But gowns, for people that are exposed that need to be clothed, after decon, we've got decon tent to deploy, relocate. We need a little assistance getting it relocated, as we don't have a earmarked vehicle for that. But, Kenny, you wanted to interject some other things?
Yeah, as far as patient support supplies, you're looking at possible burns, so fluids, drip sets, things like that, calcium gluconate for anhydrous, as much as that we can get over to them. Possible needle decompression stuff if there was an explosion for blast injuries, and also probably water and even maybe some food for the responders, and take that to the cold zone.
Thank you, Rick and Kenny. As you can tell, Kenny doesn't want to be left out there in the cold when he's responding, so he knows exactly what he wants when he's out there. So thank you, Kenny, for that. Anyone else with any other perspectives? Okay, I see Nancy. She says SCBA maybe. We also have PAPRs and CAPRs in the house. Okay. I don't know if we have any facilities who actually still use any supplied airlines for personnel that are wearing personal protective equipment at all. Most of it is now PAPRs and or full face air purifying respirators. Just a quick update. I'm putting the latest, and I've highlighted where we're at in the chat. Right there, we have about 1 minute left for the MCI alert to be completely updated, and I've highlighted those who have not updated. So HSHS Holy Family, Memorial Hospital Belleville, Memorial Hospital Shiloh, OSF St. Anthony's, Redbud, and Boyd still need to update in EM resource. So I'll just pause right there. Okay. Anyone else with potential PPE and or supply recommendations that you may have at the ready to provide EMS personnel? Lee and or Scott, I'm gonna target you guys just for.
Phil, can you repeat the question? We were having a discussion.
Sorry, just talking about the PPE and or patient support supplies that can be provided to EMS to augment their supplies in the field.
Right. Yeah. So yeah, we do, from a regional perspective, we do still have a cache of PPE equipment that is still sitting here in our storage that could be pushed out should it be necessary. That could go to, legitimately, it could go to the hospitals because it is the same equipment they're already trained to operate with. For EMS, I mean, it would be useful to a degree. However, they're not necessarily trained to operate within a PAPR or an APR. As far as the equipment caches, to Kenny's remark, yeah, calcium gluconate, all that's wonderful. It's not actually part of the stock that we keep on hand for that purpose. But every hospital that receives ambulances does have, or should have by the ESF 8 plan, a box or bag or some organized means by which to store a specific list of supplies that can be pushed out upon request within 30 minutes of that request. And I think that's kind of where we were leaning towards when we were addressing this, is to make sure everyone realizes that they need to have those bags and that they need to be up to date and inspected. The list is available. We've distributed it previously. We can send it back out again as needed. Is that what you're looking for, Phil?
Well, no, the answer's so perfect. No, yeah, that's perfectly fine. That's perfectly fine. I just want to make sure that we're touching on that as well. And what he's talking about is what's outlined in the ESF8 or the IDPH ESF8 plan and required by state statute that all hospitals must have their EMS. I'm using air quotes. You can't see them. Disaster bags at the ready, and they need to be available within 30 minutes of the request. So within that. Normally, those are some of the things that I may or may not, depending on the situation, may put in the EM resource request, but it normally you don't want to do that without, you don't want to forward, for me, as basically a multi-agency coordination system here, I don't want to send out things to an incident that are not requested. We would try to be in contact with those who are on scene and ask those questions. And if we do get a positive response back from the field stating, this is what we need, this is what we need at the scene, we need extra bandages, extra da-da-da, I'm gonna, break in case of emergency and ask all the hospitals to provide those disaster bags to the scene. Last thing we want to do is provide things that aren't going to be used or not requested by the incident commander and or the logistics staff out there on any incident. So, all right, great. Did anyone have any questions or other additional questions or comments about this portion of the exercise? Okay, great. We're going to shift down. Oh, John, I'm sorry. Go ahead, John. Thank you. So you raise your hand.
Okay.
If you're talking, okay, there you go. Gotcha.
I've tried to move a little bit so my Wi-Fi is a little stronger. Just again, I don't want to blow the exercise, but man, I've heard a lot of great conversation. But in my perspective, probably right off the bat, I'm going to lose one or two crews from exposure. I just want to, throw that out there because, they're going to pull up to this derailment and we're probably going to have, thankfully it's inside a switching yard, which is not highly populated, but it's still got, personnel working in there. So I would probably assume right out the bat, I'm going to lose 4 of my personnel to some type of exposure, probably with the chlorine releasing, probably some major respiratory issues. Again, Phil, I hate to say it, I would have probably thrown this out as a level 4 at first and would have let the region or the RHC move it to a category, a level 3. But I would have probably first thrown this out as a level 4. And again, once we truly identified that this is not a good thing, we'd have moved back and would have went into a rehab for the firefighters and the hazmat teams that would be responding. And then we would probably concentrate on the neighborhoods that would be affected. So I'm thinking that we would probably have a lot of respiratory issues that would be hitting us right off the bat. My last comment, I don't know how we do this or if you guys, I believe you can do this through the state, but like your first alert that went out that showed just the acknowledgement, what I would really like to see, again, I don't need to know what all the other private companies or municipalities as far as EMS are doing, but I would like to know that they at least acknowledge that there's an event going on. I kind of mentioned it earlier in my statement about that we had some Region 5 EMS that got stuck on 64 during the storm. They were not aware at all, or neither were the hospitals that were transporting out some, well, one of them was a critical patient, that, you know, that we had went through some devastation in the area. So they sent the crew out, and the next thing you know, they're stuck on 64, having no clue where or how to get around it. One of them run out of oxygen. I had to take them a bottle, and then we literally had to show them how to detour around. Again, I just think if that situational awareness that can be pushed out and then verified by acknowledgement, would be a great tool to add to our EM resource.
That's a great point. Great points, John. Great points. Thank you for sharing that. And I see the hand up over at Shiloh.
Yeah, it's Lee. I just want to plug in one more thing on that. When we talk about PPE from a regional perspective, another resource that we have within the region that, you know, would actually be ideal in this situation is we have a trailer that now works for decon that could be, you know, positioned as appropriate to be able to support that need. And it's how that request gets made through, you know, EM resource and through contacting the RHCC so that we can coordinate that movement.
No, makes perfect sense. Yes, our decon trailer, as for many of you who attend the coalition calls, know it's been kind of the bane of our existence since we had it. You know, it's worked and then didn't work for a long time, and we finally got a gentleman out here to really fix it up, and it's working great now. So definitely a resource that we can deploy upon that request. So, and we'll talk about that request method. So what we're going to do is, just looking at the time, we're going to go up to this next module, give a little more situational awareness, and then we will have a slightly extended break for folks to get coffee, something to drink, use the restroom, and still be able to have your discussions amongst yourselves before we return. So what I'll do is we're going to go ahead and press on into module 3. So here's a scenario update. And again, while we're 57 minutes or so ahead of this schedule right now, but around 10:30, there was an area command set up between St. Clair County and Madison County. And they're trying to make sure that they're able to manage both scenes. The two scenes that we really have to worry about is obviously where the train derailed, but the racetrack. The racetrack is by the Crow, about 1 mile away exactly from that location. Winds being around 10 miles an hour. Whatever leak there moved that way rather quickly. You know, geographically, that area is fairly similar. I think it's about 400 feet above sea level, 409 feet or 410 feet above sea level where the train derailed, and it's about 400 feet above sea level. So about a 9-foot elevation drop between those two areas. And the chemicals that we are talking about are heavier than air. So they would follow the wind and head that way. The current bridges that are closed, MLK, Poplar Street, East, Damuel, McKinley, all those bridges are basically shut down. There's no traffic going across there. They've rerouted traffic to get backwards, you know, to start going back the other way, headed east. Confirmed reports that at least one of the rail cars experienced a BLEVE, aka a boiling liquid expanding vapor explosion, and that was probably the first loud explosion that was heard. Social media reports from the racetrack show videos of mass panic. It's believed that hundreds may have been trampled trying to get to their cars. EMS has relayed evacuees of the racetrack have been cited with skin irritation, difficulty breathing, eye irritation, vomiting, nasal irritation, profusely running. The area commander has issued a shelter-in-place order east of the Mississippi, from East St. Louis, far north is Granite City, and east to Fairmont City. This is kind of a rundown of the actual or picture of what it would look like given the current scenario and the size of the rail car, and using chlorine as the primary chemical, as we did talk about the anhydrous hydrogen fluoride that we discussed as well, but this model itself is using chlorine. We're using chlorine just in this model because it would travel the furthest, as John pointed out earlier. It's more likely that that's being in a rail car. We did have I can't remember what year it is, but whether it was in Fenton or wherever, we had a major chlorine response. I would say geographically, quote unquote, locally, here several years ago, there was a major chlorine response. And that's kind of what the bridges look like. They're all red. You can get further south and then maybe make it across and go up north and maybe make it across. So that's what it kind of looks like now. And you can see all of this inside of D4H now. So if this is D4H itself, so if you were in there, you can add that layer right to the map and you can see that in real time. The fire chief, again, has made this fictitious Chief O'Malley, his shelter in place order out there. And here are our discussion questions. Again, remember, either click on the link on the slide or scan that QR code. I will put it in the chat here in a second, but let's talk about those here quickly. So first question is, John Nowak, can I get D4H help, Lee? He put that in the chat. How many staffed med-surg and ICU beds can your facility open within the next 2 hours? And please remember, this is separate from what you put for the red, yellows, and greens that you could handle in the ED. This is inpatient beds over the next 2 hours. And we still have 1, 2, 3, 4, 5, 6. The same 6 folks still have not updated EM resource. So right now, John Nowak is out there sweating. Question from the boardroom at Shiloh.
Hey, not a question, but Phil, just I've had several text messages. Yes, we're aware of the issues with the D4H login. They decided to implement a change this morning without any forewarning. So yeah, we'll get more information and try to correct that with them as soon as we can.
Okay, so just so you guys know, I pressed my luck and I went to the new server. It was painless. Everything moved over and I'm operating in it without issue. So you can do it probably right after this. Doesn't take but a second. But again, how many staff med surg and ICU beds can your facility open within the next 2 hours? You know, that's your available ones. And what can you surge to? What can you truly surge to? What are the hospital's potential limiting factors or shortfalls trying to provide care to patients of this disaster? How would the local health department communicate important public health information instructions to the affected community, including shelter-in-place orders and guidance for avoiding exposure to the released chemicals? What are the challenges associated with implementing shelter-in-place for a hospital? And what does your plan or policy state? So we'll be going to Gateway for this one, because if you go back to that photo, I'll go to it now, where that number 3 is, that's where you're at. So, all right. What strategies would your organization employ to effectively manage a large influx of casualties, including the establishment of temporary treatment areas and allocations of resources? Think not long-term surge, but immediate surge planning. You know, how do you shape shift within your organization to accommodate a large surge of patients? And how would your hospital address the specific needs of pediatric patients affected by the incident, including the appropriate medical care, emotional support, and family reunification? Okay, I'm going to, I will move over to the next slide. And again, this one, it says take 10 minutes. We'll try to take a slightly longer break. This time we'll probably take 15 minutes to do this. So we'll let this count down so folks can get to a bathroom break, get coffee, refill, and then come back and then we'll discuss. So we'll go 15 minutes. So 10 minutes plus 5. If you have any questions, I'll be here. You can put them in the chat. See you in 10 or 15. All right, that's about time there. We're gonna go ahead and return back to regular scheduled programming. Hopefully, if you guys are still working on some of those questions, we'll walk our way through those. Let's move down. So let's go back to the questions page. So, starting with the very first question, and again, this is a realistic, sober assessment question. How many staff, med surg, and ICU beds can your facility open within the next 2 hours? We'll start with Tina out in Fayette.
Hi, Phil.
Hello.
Can you hear me?
Yep, we can hear you loud and clear.
All right. So I have a couple more people that join me. And
Okay.
so with our census and our staffing still, we're having, staffing issues that we could take 5 patients for an admission. And then at that point, we would have to look at other means of transportation and other facilities that is currently around us where we could transfer patients to help us via air or via ground, just depending. So that's kind of where our staffing is. And can you tell me the next question I need to answer, please?
Well, the first one was just the number of staff beds that your facility could open within the next 2 hours. We'll get to the next one, but I'm going to kind of do a quick round robin with the folks with each one of the hospitals here.
So we could take 5.
Okay. I see Boyd just put in there, said could staff 12. Med surge, 2 ED. We do not have an ICU. So Nancy, one thing on here on your for EM resource, you guys still haven't updated what I'm looking for your ED number. So I predict maybe that's maybe a yellow and a green, or a red and a green, or red and a yellow. Those haven't been updated. So those 2. Okay. Okay, we got the good folks down in Sparta. No ICU, but we can take 6 med surge. Okay. Brad says over at St. E's, so I'm taking this is for St. E's specifically.
Yes,
Or if it's, go ahead.
yeah, we're at we're nearly peak census right now. We're already boarding. So, for instance, if we were to post up our numbers right now, we'd possibly show 3 ICU beds available, but we've got people in surgery that are going to have to occupy those. So we would be in a position, and right now, we could possibly, so it's easy to say that we could empty and transfer out a couple of our tele beds, but it requires EMS to do that. And if EMS is tasked, it's just simply not going to happen. So our approach would be slightly different, is that I don't think we could really try and find beds since they're all full right now. We would start our boarding plan and then jump down to your shelter in place and getting creative with space. So
Yeah, yep, okay. I do see John's hand up. Go ahead, John.
I hate to be cruel and mean, but I've got 100 patients that I'm going to try to start moving, and I'm coming.
Sorry, John, you were accidentally muted, but you're saying you're coming. Go ahead and unmute yourself and keep going. I'm sorry.
Okay, let's try that again. Just me, what I can see, I have 100 patients that I'm dealing with trying to get EMS, and a lot of people are clearing this track and stating that they're driving to hospitals, asking for information. We're going to be inundated. Y'all better make some room in some parking lots because we're coming.
Indeed. Okay. Let's go over to Gateway. How many staff, med surg, and/or ICU beds can your facility open within the next 2 hours?
We're talking about 4 to 6 ICU patients and 12 med surge.
Okay, great.
Now we've got,
Thank you.
okay.
Go ahead, Britt.
Well, I didn't know if you wanted me to kind of expand, given the fact, as Kenny had said, we're in that hot zone, what our
Mhm.
detriments are, what our pluses potentially could be. I didn't know if you wanted me to expand on that or just talk about the patients regarding this question.
Just that specific question for right now, and we're going to get down to some of the next spots. So,
Okay,
okay.
thank you.
No problem. I appreciate it. And let's go over to Belleville Shiloh Memorial.
Okay, we're back. So yeah, the situation here, we've been discussing this, is pretty much going to be a matter of what can we downgrade and make freely available. Yeah, 2 hours isn't a lot of time to implement such changes. But, you know, like John said, we know he's coming, so, you know, we gotta fish or.
Yeah, we're at Shiloh, we're full. We have a border in the ED. We'd have to look at what discharges we could have quickly without EMS or other options, but then staffing could be an issue too if we found other places for people.
And at Belleville this morning, we had only 10 in the ICU, so we have what, 21 beds?
Staff for 16.
After 16, so we potentially have 6 then. If we have staff for it.
Did you copy that, Phil?
Yep, I did. Nope, I did. Okay. So yeah, not only is the one thing that I will say is that when John says that he's gonna be there one way or another, he's gonna some of those folks he's gonna have to transport there. As we kind of talked about earlier, there may be some, I don't want to say field level care. John, if you'll indulge me just for a second, you know, some of the austere training we just did for doing kind of extended care in the field is probably going on, obviously, with the amount of folks. If you guys can remember I think it was a Travis Scott concert in California not too long ago. They were there from the stampede of folks over there. They were in the field for hours and hours and hours before some folks were transported because some of them could not be moved. So I'm sure we've got a lot of that going on as well. But the one thing that, as John pointed out, that he has zero impact on are those who travel via vehicle of opportunity. They don't work in this what we'd like to consider a well-oiled machine or network of communication, folks talking back and forth in D4H and all these places, EM Resource, looking at all this stuff. They're going, I live in Belleville. I'm going to go to the Memorial. I'm leaving this site now. I got out of there. I'm coughing and I'm going to Memorial as soon as I can. Yada, yada, something, something. So I do know, again, when we'll get down here in the next question, maybe the health department can help with some of that information. Okay, I see, Cindy. Okay, you said we could open 24 beds, 8 being ICU. So that would be music to John's ears, I'm sure, to see that pop up as well. I do see John's hand up. We'll go with this question and we'll go with what you got, John. Then we'll move on to the next question. Go ahead, John.
Yes, sir. Like you said, we're going to be inundated. I'm going to be hollering for help. But what's going to happen to us is we're going to have to treat in place. A lot of these things are going to be small and minor, like the face, the skin irritation and stuff like that. Getting them deconned, getting that resource to us to help. But a lot of things that, we only carry so many drugs on a truck. We don't have big caches that we can get to these people right away. So again, those med bags that you were talking about earlier would be kind of important just to keep those patients from hitting that hospital within that first 45 minutes to an hour. But again, you push this over the top of the racetrack that's holding 40,000 people. We don't have time. I mean, we're going to be here for a long time, but we don't have time to try to discharge. We got to figure out how we're going to deal with this. mobile hospitals. Again, that takes 2 to 3 hours to set up. That may be our long goal, but I'm going to need drugs and resources to treat minor injuries, to keep them out of your ERs if possible.
Hey, Phil, it's Lee. So to piggyback off what John said, and to add a little insult to injury, if you will, one of the things to think about is, we used NHRA. Well, you could use ND, NASCAR, any of those events. The other resource that's already on site, which in this case would be negated by the fact we were on site, is REMER. So the regional team that we have in place to call on for this kind of thing would already have been there, because we're already there to staff those medical events. And more than likely are part of now the affected as opposed to the effective.
Exactly. You got, yeah. I would consider you guys potentially. I would like to say your spidey senses says you would have made it out ahead of things, but you could just be a part of the chaos as well. So next question: what are hospitals? Some of the hospitals' potential limiting factors and/or shortfalls trying to provide care to patients from this disaster. And I'm going to go back over to the folks at Gateway. I think this is one of the questions, Rick, and your team we're going to kind of start to lead into. Rick and/or Kenny?
Yes, sir.
Or Daniel? Okay, go ahead.
We were talking
No problem. Go
about
ahead.
setting something up at the track, but be that as it may. So where I was earlier, and now you want me to expand a little bit on where we were with regard to being in the hot zone?
Well, just some of the limiting factors and shortfalls providing care to the patient, just given your current scenario. And if that's part of, some of your limiting factors, yes, please, expound upon that. But, if there are any other ones, feel free to discuss. Go ahead.
So this will be participated by several others around this table. I'll just start off, but so being in that hot zone, there's probably a window of time that's pretty critical to see if we are able to erect our decon tent prior to the plume arriving. If we could do that, our intent would be to put it inside the ambulance bay and then tether it to the ambulance bay entry doors into the ER, so that we would go from, as Scott would say, going from the hot zone or dirty zone into a clean zone. We'd have fans in our ER ambulance bay that would, as Kenny said, would create a pseudo negative airspace, pushing the air out of the bay. We could receive ambulatory or non-ambulatory patients and just decon them through the tent into the ER for distribution. Those are some of the limiting factors. From a staffing standpoint, interior-wise, we would convert staff that are RNs that are maybe in more of an administrative role, not knowing what time of the week or time of the day these are happening. We could do just-in-time training, buddying up with an RN, with a non-RN to assist in capacities that would not require that RN expertise, perhaps. We would have buddy-up system that would, take patients like we'd had during COVID that would be, same kind of treatment side by side, but it would kind of be a force multiplier with regard to staffing. That's just some of the ideas that come to mind. So, Kenny, you can certainly expand more on that and/or else.
So my thing is that, whenever we talk about EMS, we're always looking out, and we're going to do what's best for ourselves as providers first. So I don't see many ambulances regardless coming to Gateway, assuming that the plume is either on its way or over us already, because that would put them at risk, and then you have the ventilation systems bringing it in. So if anything, I would say we would have to worry about more of the ambulatory people getting into trucks and coming out. And with that, if Gateway has a big board, we could get into contact with them and try to get the racetrack to put, go this way, go to a different hospital. If we had first responder drones with the loudspeakers, any way we could do to divert them away from our hospital, not because we didn't want to treat them, but because it was just going to cause more harm than good. That I would see being the one of the better things to happen for the providers on the ambulance and the patients themselves.
Great observations, Kenny. Thank you. Thanks to the folks at Gateway. Let's go over to St. E's. What are some of your potential limiting factors or shortfalls trying to provide care to these specific patients in this scenario?
We're set up for decon and so forth, so I don't see any particular, volume is our limitation right now. That's the only thing we're worried about. The actual treatment and so forth, supply wise, we're pretty set. That's the one thing COVID did for us is that we have an abundance of supply when it comes to the materials and stuff that we need to decon, and then just the general treatment. I think we've got a pretty good cache. So the only thing that we are talking about right now as this is going on is manpower and setting up where we're going to put our patients. Moving on down your list a little bit. Of what are we going to effectively set up to be able to put our patients in place. But we have our tent for deconning, we have our decon room, and we have plenty of pepper style equipment and so forth. So.
Okay, thank you, Brad. So let's move over to our health department. So what would the local health department communicate during this type of incident? We did talk a little bit earlier about shelter in place orders and guidance for exposure control for the released chemicals. What are any other additional public health service announcements are you providing to the populace to maybe assist the hospitals from potentially being overrun with patients? And I don't know if Wendy or Vicky wanted to tackle that one. I'm trying to look back in the chat to see exactly who we have on again. Either Wendy, Vicky, or Deborah.
So that's a tough one, but probably there would definitely be social media involved. So we would probably put things out because people do use Facebook to see what's going on with things. Definitely important public health information. Sheltering in place, of course, the local radio would be something we would use. Probably, in fact, because of the timeliness of this, there may be an issue with even having, especially really close to the hot zone, possibly have law enforcement personnel go out and actually use the loudspeaker to announce shelter in place. Those are some options. Like I said, social media is pretty powerful, though. We could use our alert system like we do for other weather emergencies. We do have that people in the community that subscribe to it, I'm sure we all have some type of system similar. Those would be some things to get the information out for shelter in place. And then also probably would have our volunteers come in to man the phones because people are going to call us.
Great. Thank you. Thank you, Wendy. Are there any opportunities here for us to, for those potential greens, the twisted ankles, the small stuff, so to speak, to reroute them I know Kenny talked about drones, some drones and a few other things, but to reroute them to potential urgent cares and or other locations that are not labeled emergency department that are there. I know we don't have a standing spot for this type of, we don't have a standing checklist or anyone that owns that, but is that a potential possibility? I know that there are some issues with regard to EMTALA that we want to definitely stay out of, especially when providing care as an ED that's not on bypass. But at some point, when it's broken, um, do we initiate a bypass for I'm going to use St. E's right now. Let's say they're having the biggest struggle because they're packed, they can't get any more staff in, they stretch as thin as they can go. Do they go to um, again, do they go to or request a bypass, initiate a request for 1135 waiver for alternate care planning, and start to reroute some of those folks to their urgent cares? Brad, I don't know if you guys have talked about that in any of your alternate care site planning, but how much of that do you think is an option given the current scenario? Brad, if you are chatting, you are muted. Maybe Brad had to step away for a moment. But anyone with any conversation regarding that and the use of urgent cares in and around the community to support this type of response and
Hey, Phil,
preserve
this
some
is
of the ED?
Hey, Phil,
Go
this
ahead.
is Dale at Sparta. We did have a conversation about that. We do have an offsite convenient care facility where we would send those greens to. But we also have a couple of mobile clinics that we know that we could mobilize out in the front of the parking lot of this convenient care also. So we could actually take a pretty good influx of green patients through those ways.
Did you guys do this in part during COVID?
We did. Our mobile units came out of COVID. It was determined that we would have these mobile units to be able to go to the outlying communities, to be able to do swabs, to do testing, and then we continue to use these mobile clinics now just as an outreach to these other communities for people that can't get here.
They serve as a rural health program.
Perfect. Thank you. Anyone else with any conversation on that? Go ahead, John.
Hey, sir, at this point, I don't know how far, what time frame we're into, but if this would be considered, again, I started it out at a level 4, and we would definitely be into a level 3, maybe even stepping into a level 2, especially with the racetrack, possibly 40,000 people being involved. But at some point in time, would not the counties have already declared an emergency? And if the governor was brought into that action to declare a state emergency, would that not open the doors for a lot of the items that you are talking about right now?
Yes, it would. It would probably be, within the hour. And right now we would be at basically, I'm trying to let me look at the last time frame. Yeah, so at 10:30. And so we're somewhere between 10:30, 10:45, so roughly 45 minutes into it. So, whoever, um, the county commissioners and whomever who have been talking with the state, they would have at some point, and I don't know how soon this would be enacted, but yes, this would make national news, um, depending, especially on the number of casualties from the racetrack. But it definitely would make national news, and I would presume that the state would enact a state disaster. And because it may deal with across state lines, because we are close, and we've kind of we've shaped this so the winds aren't going directly west or, just fully impacting St. Louis. But there are some issues there as well. But yes, that would open up a lot of things if the state declared a state emergency. But that does not preclude any of the hospitals from requesting an 1135 waiver when enacting any of their alternate care site issues. And I know we don't have Greg on the line, but that's definitely something that we would, it's one of the things that I would be pushing Jeff and Ms. McManus and John here to do, is that, that because that will alleviate some of the worries. And we want to get folks that we can take care of away from the ED, so we can make room for those who are the most serious. Because we don't want to do a bunch of twisted ankles and maybe, maybe a fractured wrist, from falling and stuff like that. You want to avoid those things and get them out to those care clinics, urgent care, et cetera. All right.
One last thing.
Go ahead, John.
Our 911 has not stopped. So my cardiac arrest, my cardiac arrest coming out of Belleville has to have a place to go.
Exactly. Yep. Gunshot, the GSW's got to have somewhere to go. The cardiac arrest. You're absolutely right. None of that stops, So, we have enacted at this point. I would say also we're doing a lot of the St. Louis based ambulance services have received. I would say have probably received the go ahead to come across and provide support as well. So I'm going to go just quickly back up to the folks at Gateway with regard to their shelter in place plans. One, do you guys have a shelter in place plan that may be co-located with your evacuation plan, or maybe a standalone plan or policy that dictates how you guys would shelter in place?
Well, first thing we do is turn off air handlers so we wouldn't pull in any outside air. About a year ago, when we had that recycle plant go down, we did shelter in place as per Madison County, so it was broad-based, much more so than just the hospital. So we'd anticipate that. Whoever'd be here on site, we could accommodate staff overnight depending on what the conditions were and the length of time. Depending on who showed up at our doors, how we would be able to treat those. We have plenty of rooms to accommodate in beds, so even for people that wouldn't need care, but just accommodation.
And considering that we wouldn't be able to actually call in staff like other hospitals, since we are in the hot zone, going back to what you had said before, we do have some urgent cares, and we could actually call in staff to those urgent cares and provide care from those sites as alternate care sites.
Great. Okay. Well, thank you there. Let's talk a little bit about your internal management of the influx of casualties. How does that look when you guys are expanding or preparing to receive folks from an MCI? And I'm going to start with, let's start with the folks at down in Sparta. How do you guys do, MCI response there? Do you send folks to a certain location where your red, yellows, and greens go, et cetera?
Yes. If we know that we're going to have an influx of patients, we're going to call our code yellow, which is our incident management, and then our nurse manager, either in both in ER and on med surg, are going to look at our current census, and then determine which ones can be discharged, possibly which ones could be moved maybe to an alternate site if it came down to that. And then that way we would be able to understand how many rooms we would have available. The staffing, of course, is going to be based on what we have here at the time. And of course, generally these things are always going to happen at 2 o'clock in the morning when your staffing is lowest. But we do have the availability of bringing resources, staffing resources in if the incident grew larger than what the current staffing could handle.
We would also do the same for surgery, look at the surgery schedule, what could be canceled that day, because the surgery pool is a large pool of our RNs. And if we can pull majority of those, that would be a great resource for us as well.
Perfect, perfect. And how about the folks over here at Belleville and Shiloh Memorial?
Okay, we're coming back on. Anyone want to take a stab at it? So we're looking again, Phil, at the strategies for taking the influx, or which one are we on here?
Correct. Yep. Yep. How we initiate our MCI plans.
We would, I think we discussed this earlier, look at our current staff, our current census, and who we could immediately discharge, again, without EMS support, because that would be difficult. Also look at our staffing needs and our, other options for where we could place patients. Be at the bay and the ER if that wasn't occupied, or stretchers in the cath lab, whatever we would have to do, but we'd have to look at staffing for that.
And the notification component of it will be done via our normal Everbridge and, overhouse announcements, depending upon, again, time of day and conditions. As far as, obviously our biggest concern, like everyone else's, having people to do things. We have stuff and we just don't have staff. We do have the plan that establishes the alternate treatment sites. And should it be necessary, we do have the off-site alternate treatment site that could be done. However, that does require that 1135 waiver to be initiated.
Okay. And lastly, how would your hospitals address the specific needs of pediatric patients affected by the incident, to include medical care and emotional support, family reunification? And let's go to Brad. How are you guys addressing pediatrics? Again, family reunification, appropriate care, et cetera, during this type of scenario?
Because we've incorporated a pediatric surge that is just getting started right now with this drill. So we would do our notifications of our pediatric surge, which we consider anything that is 3 patients or more that is pediatric related. So we do a notification process that is house-wide. Halo product to get assistance down here with that. We have reviewed our reunification process. We do have Instamatic cameras. We do have a dedicated spot for putting patients that do need, pediatric patients that do not need to occupy hospital rooms. So we do have a dedicated spot for that, which would be manned at all time. We also call O'Fallon Police Department to assist us with the reunification, and anything that has any volume to it beyond that, we depend then on the Red Cross for that. We do utilize the photo Instamatic system. So we take a picture, an Instamatic photo picture of all of our pediatric patients, and use that as part of our reunification.
Perfect. Tina out in Fayette, how are you guys dealing with reunification of children, unaccompanied minors, and/or patients?
I'm just going to add to what Brad just said. We're actually going to be doing a tabletop exercise in August about that. So we also, in case there's any kind of fatalities We would also include the coroner with help with identification, and of course the Red Cross. We would have our local health department help be involved with that, which is part of the EMA. So we'd utilize those also. We have a designated area for those children who really do not need any kind of formal care, but also to the identification, like Brad was talking about with having the photos immediately available. And then we're also going to use the form that's currently, one of the forms we're using is the one that's currently in the Hope Coalition, in that pediatric reunification plan that is out for the coalition. And I think that's about it.
Awesome, awesome. And I should pull up a picture of that. But yeah, that's great to hear that you got that plan is at least providing some useful tools. We do have a pediatric surge plan for the coalition. And, you know, in this instance, I normally would say that most events, you know, kind of follow the census of around 26% of those incidents, unless they're specifically related with pediatrics, are going to be part of your patient population from any incident. So we all need to make sure that we are prepared for those types of scenarios. Before we move on, just let you guys know, we're about right on time, which is good. And I'm going to provide you with a kind of breakdown of the patient population or the patient distribution. I don't call it a model, but for whatever it is, it's the patient distribution for this exercise here soon. So you kind of can see, you know, well, what you said that you would be prepared for, this is exactly what you received. So we'll discuss that here shortly. So any questions, concerns about the response portion here or this module before we move on to the treatment module? All right, let's move on to the next one. So in module 4, here's our update. This is where now we're right at 1 hour into the incident. So patients of varying degrees of acuity start to arrive at local hospitals via vehicle of opportunity. Delays in EMS response times continue to increase traffic and safe routes from the scene making safe routes from the scene more and more challenging. EMS and fire personnel continue to provide extended field care to patients at the racetrack. Initial attendance estimate at the racetrack was roughly 15,000 early arrivals before things got on. They're all the tailgaters and just basic staff. The WWT Raceway Incident Commander believes 750 casualties of varying degrees of severity are present at the racetrack. Many suffer from chemical burns, respiratory distress, physical injuries from the stampede of attendees. The derailment incident commander believes there are roughly 100 casualties of similar disposition as the raceway. So that's what you're kind of looking at there. So that's around 850, at least estimated, that both incident commanders are kind of looking at. So here's the discussion portion here. Says, what resources did your organization utilize to assist with determining treatment protocols for chemical exposures? How many trained operations level first receivers are on duty at your hospital today? So that is a go out and find that answer kind of question. Probably not going to get that right in the boardroom or wherever you're formulated at right now. What immediate medical treatments, interventions, or countermeasures would your organization prioritize for patients with dermal exposure to chlorine and hydrogen fluoride, considering the corrosive nature of the chemicals? How would your organization provide medical care for patients with inhalation or ingestion exposures to chlorine and hydrogen fluoride, considering its potential cause for respiratory and gastrointestinal distress and airway irritation? How would your organization coordinate with local health departments to conduct surveillance and monitoring of affected population to identify and address potential long-term health effects? And lastly, does your facility management plan incorporate proper handling of contaminated remains or contaminated decedents, is I guess probably a better term or phrase. I'm going to let you guys sit with that. And inside the chat, I'm going to submit what each one of the hospitals across the coalition started to receive from this. So this will be within 1 hour and going forward. This is the total amount that you guys would have received from that incident. So I'm going to go ahead and start the clock and just take a look in the chat here in about a minute or so. You'll see the information. So let's go ahead. Let's take 10 minutes so you guys can discuss and we'll come back. right, let's return. This is the last module here. So let's go ahead and get started. So starting with the first question says, what resources does your organization utilize to assist with determining treatment protocols for chemical exposures? I will start this one with the good folks over in Belleville and Shiloh.
I'm sorry, Phil, can you say again? We were having a conversation still.
All right, first question, what resources does the organization utilize to assist with determining treatment protocols for chemical exposures?
Well, so we had that discussion and we have elected to phone a friend. More than likely, we're going to be reaching to our counterparts within WashU and BJH to look for some guidance assistance. Should that fail, we also have access to the Chem website from the National Institute of Health, as well as the Chem Warfare Treatment Handbook that was given out by the coalition a couple of years back.
Injury, but I don't think.
Phil, did you copy?
Yeah. I see Dale's on, but all right, let's go over to.
I'm sorry, Phil, did you ask a question? I didn't hear you if you did. This is Dale.
Yeah. Yes, sir. Just was asking first on the first one, what resources does your organization utilize to assist with determining treatment protocols for chemical exposures?
Well, we'd certainly use poison control.
Okay.
And we would reach out to our, I guess it depends on the expertise and knowledge of our ER doc of the day. If it's a common chemical or hazard that there is their standard practice, but if it's something a little more on the fringe, like maybe the two today, we would reach out to poison control or some of the St. Louis hospitals that we use for our typical transfer patterns.
Perfect. Thank you. All right. Let's go back to my personnel window. Give me one sec. Let's talk with the EMS folks. So John, what resources do you guys utilize? I know some of them you're gonna say, but what resources do you guys utilize to help with treating chemical exposures in the field?
Sorry, guys, I've moved mobile, so I have trouble hearing.
Okay.
Anyway, Phil, right from the beginning, REMERT is not just REMERT, but our St. Clair County Special Services. They have two of the most wonderful chemical engineers that are with them, and along with many doctors that are connected from both sides of the river. We'd have been reaching out to them to ask for support and help, which, at the track, they probably would have been there. But we would have been reaching out for multiple resources from both sides of the river for strike teams. Again, one of our biggest thing is that those drugs to help treat that initial respiratory issues is what we're going to have the most of. Yes, we're going to have chemical burns on bodies, but the respiratory issues is what we're really going to have problems with, and that's what we would be hollering for probably the most part.
Got it. Okay. Started at using today as a starting point. How many trained operations level first receivers are on duty at the hospital that you're at right now? So we'll go with pull back up my list of folks again. Sorry, between the chat and that. So we'll start with Belleville here. So we'll start with Dennis. I see Dennis is still on.
Sorry, Phil, what was the question or which one are we on?
Number 2. trained operations first level responders on duty today in your ED right now?
As far as, I think I have a couple of techs that are on that can work in the decontam shower, but that would be it.
Okay, and did we make it over to Shiloh? I don't know if Kim is in the boardroom with you guys.
Are we on today?
None.
None of my stuff today.
Okay,
27 patients, I thought.
I didn't hear the last part, sorry.
Nada.
Okay, how about good folks back up at Gateway, either Rick or Danielle?
Yeah, we've got roughly 10 to 12 on site right now.
Okay, awesome, thank you. And how about Tina Fayette?
Currently, we have 5.
5, okay, awesome. All right, so we'll move over to the third question. What immediate medical treatments and interventions or countermeasures would your organization prioritize for patients with dermal exposure to chlorine and hydrogen fluoride, considering the corrosive nature of the chemicals? We'll go right back to I think because Kenny started talking about this earlier, we'll go right back to Gateway.
You want to hear that question? Can you repeat the question,
It's
Phil?
3. What immediate medical treatments or interventions, countermeasures would your organization prioritize for patients with dermal exposure to chlorine and hydrogen fluoride, considering the corrosive nature of each of the chemicals?
So chlorine's gonna be just mostly decon, just getting it off of them. And then the hydrogen fluoride or anhydrous, once again, we're gonna be grossly deconning them with water. And then you could use for the dermal burns, the calcium gluconate, whether you mix that into saline or if you make your own gel and put that on the patient.
Very nice. Okay. Any others? Anyone else with any additional thoughts on treatment protocols for hydrogen fluoride or chlorine? Okay, hearing none. I guess I'm gonna do an ad lib question here. Well, as you guys can see in the chat, I posted in the chat the total number of patients and casualties from the incident so far, and where they've all gone. I know last night in looking at the notes from Greg Atterbury, like he put out, he sent me a note. Where'd it go? Give me one quick sec. From the MCI last night, so 2, 4, 8, 11, 12, 15, and 17. So 15 people from the 3-car or 3 semi and Greyhound bus accident yesterday, 7 refusals that you had there. Out of here, we had a total of 423 that have sought treatment. Only 20% of those patients were transported to your hospitals via ambulance. That's how stretched thin the ambulances are right now, and there's still continuing to treat folks on scene. As we talked about earlier, there were upwards of 850 casualties that were estimated at the time, and 426 have left both sites and made it to your doorsteps. But again, only 20% that you have any direct control over were there. So that's right around 21% of the licensed beds that we have here. understanding the nature of calcium gluconate, or at least how we receive that, I'm gonna lean over to my pharmacy folks that are on, both Ryan Massey and or Danielle. Can you talk about what quantities of that do you guys normally keep, and how many folks could you actually treat? Let's say that had dermal burns or were affected dermally by calcium gluconate. How many folks could you probably treat on a given day with these type of injuries?
You guys smoke or scissors? Okay, I'll be next.
Go ahead,
This
Danielle.
is Danielle. A quick count of our calcium gluconate vials. I have 43. So depending on how many vials each patient might need, I think that I would barely have enough to get the yellows and the reds here, without any additional, and we wouldn't have any ability to get more from anywhere else if we were shelter in place. So we would be extremely limited, but as far as other treatments like nebulizers, the lidocaine that may need to go in the nebulizer and bicarb, we have, unless there's a severe drug shortage, which right now we're doing okay, we would have plenty.
So you're saying that of that 57, because so 57, and you took a basic percentage of that based on the numbers I gave you earlier, you'd be kind of close, is what you're saying. Yeah,
We
pretty
have
close.
like maybe 20 reds and yellows,
Mm-hmm.
and assuming the greens didn't need a lot of that medication, either bathed or nebulized or whatever it may be in their eyes, I'm not really certain how many vials it would take per patient.
Got it. Okay. And Ryan Massey, I see you're on. How are we kind of postured at Memorial? Are we in a similar situation? Will we be in a similar situation? Ryan, if you are talking, you are muted. Once, twice, thrice. All right. No dice. Okay. Are there any other precautions that we need to worry about with regard to maybe the ingestion of either of these two chemicals? Well, probably is kind of highly unlikely that we're going to have some folks ingestion, but what you do, I see you. Okay. I'll come right back to you, Ryan. Are there any other things that we want to avoid when treating these patients, that may have ingested some of this, while again, it's unlikely, there are those instances where folks do have food and water out there and they just aren't paying attention and they have consumed some of whatever the product is, in this case, either hydrogen fluoride or chlorine, or things we want to avoid in their treatment. John, I saw your face. I didn't know if you're about to jump in and say what we're going to avoid. Okay. So hearing nothing, let me go back to Ryan. Go ahead, Ryan. Shows you unmuted, but I don't hear you. Nope, still not hearing you. Says we're in, okay, you got it here. Okay. Are in a similar situation as Gateway without having an accurate count offhand. Calcium gluconate has been on and off shortage recently, but we're okay as of today. Okay. And I think I'm trying to look at what do we have for Belleville, Memorial Hospital, Belleville, 47 patients. So somewhere in the neighborhood of 30, plus another 10, another 40%. So yeah, around 20 patients that we'd be dealing with those type of injuries. Okay. Lastly, I think we've hit this one. While we didn't get to um, the ingestion portion, there are instances in which you don't. I'll just say there are instances in which you don't want to force someone to vomit. So again, contacting poison control and looking at whether it's an SDS safety data sheet on hydrogen fluoride or calcium gluconate. Um, you will see that in the notes regarding it. Do not induce vomiting. And that, let me just double check. Yeah. Yeah, and that's for chlorine specifically. For anybody who have any gastrointestinal issues with regard to chlorine. All right. Lastly, fatality management incorporated in properly handling contaminated remains. I know we did a lot of this through COVID, but those were biologically contaminated remains. Are your plans today updated to put this into account or to take this into account with regard to chemicals and how are we addressing this day to day, well, I won't say day to day in scenarios like this. Let's start with Tina out at Fayette. Tina, if you are talking, you are muted. Okay. I'm not sure if you are completely unmuted, but cannot hear you, Tina. Let's go over to
Bill,
there you
I
go.
had to take a bathroom break.
Okay, no problem. All right, so we'll go over to the folks over here at Memorial in Belleville. In our fatality management plan, are we incorporating and looking at handling of contaminated remains or decedents?
I'm sorry, Phil, was that directed at Melvin?
Yep.
Okay, so our plan as per outlined in our decontamination plan is that basically we don't decon the dead. Our goal is to affect the living. We'll take those contaminated remains and move them, discreetly as far out of sight as possible, with still within the containment area, and continue to press on with those we can help. The the notice would be given to the coroner to make sure that they're aware that these decedents are here and that they are still contaminated. But at that point, our liability is to the living, not to those that aren't.
Bill, and those that come to the hospital would be grossly decontaminated on scene and then go through our showers as well, correct?
Well, I mean, not
some
In a
of them.
perfect world.
Yeah, if they're coming in and they black tag on the way in, then yeah, we're not going to do anything further with them.
Right, we're not transporting the black, right?
No, but I mean, if you have one that is basically declared as it arrives.
Correct, okay.
The ones that, if we have an incident in the hospital, they will have already gone through gross and technical decon before they get to that phase, at which point they would be treated as just a normal patient who, has an unfortunate event.
Okay, so yeah, two things to worry about there. Yeah, you can have someone who is transported via vehicle of opportunity, and again, let's say in the back of the truck, and yeah, they're not riding in the cab with whoever's transporting them, and they decompensate rapidly, but they make it to your steps alive, and unfortunately succumb to their injuries either in the course of treatment or getting them to decon so you can work them. At that point, they're ours, and we have to manage that accordingly. Back over to Gateway. thoughts on potentially managing or handling contaminated decedents?
Well, during COVID, we tried to set up a, temporary morgue. That never really came to fruition because we never had the demand. We worked closely with Madison County Coroner's Office. In this type of situation, we've got a morgue. It's not a very large morgue. Depending on how many fatalities we have, that could obviously be strained. Depending on the time of year, I mean, if it's winter and it's 2 degrees outside, I mean, there's a solution right there. But if it's, this week or when it's 103 degrees or whatever, we may convert a freezer, offload all the food products and put them in a deep freeze. I mean, whatever would needed to be happening.
Call the trucking company and get a reefer unit, or get a reefer.
Yeah, we tried that and that went south fast.
Oh.
Yeah, Prairie Farms, they didn't want their name on the side of the more.
Well, I recall that. So yeah, I would say this also. You do have, remember, regionally, we do have at least a morgue trailer that can hold up to 28 patients who have passed on. So we could mobilize that. I think in a situation like this, it would probably be best to mobilize it and put it in a central location where folks can get it to it instead of putting it at a single hospital. But
Sure.
Those things are, would probably be up for discussion at that point, because I'm sure that, just like you said, we probably want that may be happening at multiple locations, and we got to make sure folks can get to it. And it is a nondescript white van instead of, saying Prairie Farms or something like that on the side of it. Very nice. Okay. And lastly, I would like to get the EMS perspective. So John, for you guys that are out in the field, can you talk to just a little bit of, when folks are being triaged, coded black, out there in the field and pass on there, what that looks like in the field. And I'm not sure if we've dealt with any contaminated bodies before the coroner comes and picks them up. Do you have any insight on that?
Again, guys, you might pick up some road noise from me because I'm mobile. Yes, this is pretty simple for us. We're going to get them out of our way, and we're going to treat it as a crime scene. Even though it's an accident, it's still going to be investigated. So we're get them moved out of our area. We're not, our treatment areas. What we're going to do with them, again, out at the track is one thing, but even residential, if they're residential, that's where they're going to stay until the coroner can, get that contact. If they're in the rail yard, again, they're probably going to stay where they're at because of a possible criminal or, whatever investigation. Out at the track where we're actually trying to treat multiple people, we're going to get them out of our treatment area. Again, once you gross decon them, you're going to knock most of that chemical off. So if we could just get them moved out of our treatment areas is what we're going to do.
Gotcha. Perfect. And I wish, unfortunately, I should have just asked this to John yesterday, John Perry, who works for the coroner's office here. Yesterday, I should have gave this question to him so he could provide some feedback. He's not here in the office today, but I'm sure he may have had a little bit of insight on just the handling of contaminated remains as well. So, all right, with that concludes module 4. News is now reporting that tomorrow they will have the director of the NTSB on here in St. Louis to talk about the train derailment. So make sure you guys are all tuned in. You may be on television, and it'll probably be John and or the Remert team out at the racetrack, I'm pretty sure, or maybe some of the SES guys at the hazmat incident performing decon or stopping a rupture or a leak. So I would note that At this point, at a prolonged event, now we've gone on, let's say at this point, this afternoon, while patients have slowly subsided from coming to your doors and being transported, at this point, it becomes an information gathering. Again, if you go back and look at what occurred during the Palestine incident, the East Palestine incident, constant news coverage. Again, this would make national news and it will be constant for the next week to 2 weeks. So I can only ask you guys to um, brush up on your public speaking skills. You know, I mean, sometimes you can just say no comment, but I'm sure there would be plenty of lawsuits and things like that, and investigative reporters want to find out. And I can just tell you from history. Um, I remember during the Korean Airlines crash back when I was in Guam. This is back in the late 90s. And I was watching my commander on television, Colonel Anderson, be asked by like, I don't know, it wasn't CNN at the time, but it was a major cable news network that was out there asking him at what point did rescue operations stop and search and recovery operations begin. And I was at home typing in the log of events. I was converting it to a digital form at that point in time. And he couldn't directly answer that question, but there were lots of folks that wanted that were trying to sue. So um, always, talk with your lawyers, counterparts, and brush up on your public affairs abilities in public speaking, because you never know, you may be out there on TV. I would recommend oh, I see Lee just put something there. Okay, I'll talk about that here in a second. I would recommend taking the CERC training. That's the Critical Emergency Response Communications course. That is a great course offered by FEMA. It comes around every now and then. IDPH has had it at the summit in years prior, which is great. It is something in our communications plan here at Memorial Hospital that we incorporate into our planning process, and we do use their kind of like acronym for being, on point, on time, blah blah blah, that they have in there. So I would again recommend that for anyone that has to be in front of a camera. If you're in any part of your command structure, having some form of media training is essential. So don't just go out there all willy-nilly, as they say. Lee did say he put in a plug for Cameo Chemicals at NOAA.gov. It is a great resource for finding information. Some of you may know, but the Wiser app is no longer supported anymore. So that is defunct as of June of this year. It is not receiving any additional funding and will receive no additional updates. And I would tell you right now that that would be an ED's emergency department and or EMS professional best friend. Had lots of great information, very easy to search. If you have it on your phone or tablet now as a standalone app, great that you have it. Don't delete it. So whatever you do, don't delete it, because you will not be able to reinstall it again. You may be able to side load it on an Android device, to be quite honest, because there are some versions out there. We went and looked about a month ago. We went back out to look to see, but please have that readily available for you. I'm going to open the floor. Questions, concerns, thoughts on what we've kind of gone through today. We're right at the 3-hour point. We're going to provide you more of a follow-up for a general hot wash for this one. We're not going to extend it out through today. There will be a basic survey that's going to go out to everyone that I'll ask you guys to fill out. But I want to open the floor for any comments, questions, concerns, needs, things that we want to address now immediately after going through this. So I'll pause right now and don't everybody shout out at once.
Hey, Phil, this is Kenny from Gateway. How would you handle a Gateway situation if we were in the hot zone over the plume and you have 57 patients wanting to come in, whether by, personally owned vehicle or like, how do you make that work? Or do you kind of treat it like a black scenario for MCI?
So in those instances, if this, I'll put it to you like this. If it was a zombie apocalypse, don't let anyone in the door, okay? But this isn't a zombie apocalypse. So in this instance, I would say use your senses, and I mean like your five senses. The canary in the coal mine kind of methodology works. What we provide you, well, what you saw is a drawing, something that we produced out of I can't remember the app. I need to go ahead and because I need to plug this app because this is the app that you want. Give me one quick second. But needless to say, that is it's CERES, CERES. I would recommend everyone, especially if you're on a first responder, emergency responder, and hospitals is probably good to have. But it does do those plots, plumes, etc. But again, those are plots, plumes, yada yada. They are figments of the imagination until I have someone from SES or Madison Heights or Madison County Hazmat or someone that says it's right out here outside your door. If you have people that are at your facility needing to get in and you are directed to shelter in place, the proper thing to do is to ensure that you allow them in because they are, it's not like they're outside dying and gagging. We used to have an old kind of, I won't call it a saying, but if they're coming over the wire and they're not in gas masks and they're making their way up to your defensive fighting position, you probably don't have to worry about that there are chemicals outside because they're not killing themselves. Same here, that you would use them as indicators as to what the atmosphere is like and to allow them in. Now, if you are in a position where there is, because we can see a chlorine cloud, and we've seen plenty of videos and responses from that. My advice would be to one, elevate. So for your shelter in place plans, well, after you shut down the HVAC, get people off the first floor out of basements and get them up to a second floor. At a minimum, and then even higher if you can. And at that point, you may not see anyone out there. You'd probably brought in your security personnel, et cetera. So you got to kind of play it by ear. And again, another reason why working with hand in hand with your local health department, getting your 1135 waiver established, getting information out to say, please don't come here. We are in a hazardous environment and your care will be jeopardized if you do come here. Please go to our neighboring facilities if you're like we talked about urgent care and or our regional partners. Go to Memorial, go east, do not come here. Or go west if you can get across the bridge, et cetera, et cetera. So it's not we'll never probably have a cut and dry answer for that one. So Tina, good folks at Fayette.
Hi, Phil. We was just wanting to know, I know you mentioned that you would send this out in a PDF, and the only reason I'm asking again is because our deadline for Joint Commission is they have to be here Monday.
Oh, wow. Okay. Yeah, I'll send it out right after this meeting. So you'll at least see this. We won't have the AAR fully done, but we will have this uploaded to our YouTube channel, so you can at least go back out there and say, listen, this is me, this is us, we're participating. They're not gonna have the AAR done for a couple weeks maybe. We try to get done within 30 days, so and get it back out to you. So but you participate. Tell them call me, or if not, no, tell them call Lee.
All right, Lee, you might get a call.
No problem.
All right. Anyone else? Questions, concerns, thoughts about scenario? First, I try not to. We try not to make up anything that's not plausible. This is very plausible for us and where we're at. We've had what was the last big fire we had out at the rail yard?
It was lithium battery. Was the last big fire. That was the one in Madison, the recycling plant.
Okay.
And then we had the chemical release in Wood River that was on the rail yard. And we had a chemical fire in Dupo on a rail
And the
yard.
Dupo one, yeah, and that was on the rail yard. So yeah. We've lucked out, even though we had the one train derailment here in Belleville back in 2017. Luckily, no hazmat, at least no, and definitely no pressurized stuff. But when you saw that there was a BLEVE, that again, the boiling liquid expanding vapor explosion, that's a big deal. So, and probably would have ruptured multiple of the other cars. Maybe they wouldn't go through a full BLEVE, but the hazmat technicians that would have went out there would have had their hands completely full. That would have, I mean, they'd be working that scene for days on end, hopefully able to close some of those gaps. A lot of that chemical would have evacuated very rapidly from those cargo tanks. So that's a good thing. And then just so you know, if the winds would have stayed the way they were, that chlorine for that would not have lasted over the total duration of an hour unless the leak was stemmed. And if the leak was that slow of a leak, it wouldn't have traveled that far. So that was the plume that you saw that we used. That was from an instantaneous a rupture. But again, that's why we used the BLEVE for that to travel that distance. So I would, just historically speaking, I would say that probably would have, within the hour, would have dissipated for most of that area. There would have been some in some low-lying areas, but probably would not have stayed too long as out there at the racetrack, and definitely wouldn't have probably made it, just in my opinion, all the way up to Gateway. So you probably would have been in a precautionary shelter in place, which is prudent, which is totally prudent, but realistically, it may have never really made it up to you guys, which is a good thing. Okay, anything else around coalition? Going once, twice. John, gotcha. Go ahead, sir.
Hey, just to remember, the greatest tool that we have is communications. The more we know, the better we can respond. That's all. That's all I'll say, buddy.
I appreciate it, John. Bring some of that to when we'll do another hot wash in this, but the plug is lead plug Cameo Chemicals. I'll plug, making sure you're jumping into D4H and you are updating EM Resource and staying in tune there. So you know what your fellow hospitals have available and communicate that way. Get in D4H, chat, talk, making sure that we're all on the same page. So that we have that for all of our local health departments. And I know we fixed accounts for Deb today, maybe a few others over the last couple of days. That's why we do these exercises. So when we see holes, we fill those gaps, and it only helps out in the end. So, all right. We're gonna leave it there. I appreciate everyone's time. Thank you for joining us. This knocks out one of our big tasks for the year, and hopefully this will help us grow as a coalition and make us better planners, resource coordination, all of that. It all works out better for us in the end. So thank you. We're going to end it here. Take care.